We have one of our visiting professors here in the Department of Gastroenterology who is going to share some of her expertise with us. To introduce our speaker today, I'm going to invite Dr. Jasmohan Bajaj. He is a professor in the Internal Medicine Division of Gastroenterology, both here at the VCU campus and at the Richmond. He's also the co-editor of the American Journal of Gastroenterology. Dr. Bajaj, if you want to introduce Dr. Lauridsen to our audience, we'll go ahead and get started.
Thank you so much for this opportunity. I hope you can all hear me. I am so happy to introduce Dr. Lauridsen. Mette has been working with us off and on for the last more than a decade, and she's here to visit our department for the last 8 months. She's currently the head of GI and hepatology research and a clinical hepatologist at the University Hospital of Southern Denmark in Esbjerg. She has been really instrumental in creating not only an ecosystem of research around cirrhosis and brain dysfunction, but also around MASLD, and she's established the liver research group there as well. Currently, she's doing a lot of studies, biobank-driven human clinical and translational studies, and she has established the SDOI, which is the South Danish Overweight Initiative. Here she has done, she's completed the Higher Ground Leadership Program at VCU, as well as is here on a very prestigious Fulbright scholarship. She's also a certified research and project manager from the Copenhagen Business School. And I am so delighted to have Mette here twice. She was here in 2015 for 6 months, and here she's been working with our group on many projects. We look forward to hearing what she has to say.
Thank you, Jeff.
There you go. Yep.
And thank you for giving me the opportunity to present here. I'm going to be talking about MASLD, and I'm going to focus on inequities in MASLD, but also in cirrhosis. And that's because it's a general topic in my research. And I'm going to share with you today some brand new data that I just analyzed yesterday. So you will be learning something new, I guarantee it. As Jas said, I'm from Denmark, and you're probably aware that it's a country north of Germany, tucked in between Norway and Sweden. I'm just going to spend a couple of minutes telling you a little bit about how it is to be a doctor in Denmark, because I've come to realize that it's quite different from here in some aspects, at least. I don't know if you're aware, but in Denmark, we pay 50% in taxes of our salary. And that buys us a lot of public welfare. And we have free education all through university, which is nice, and also free healthcare for everyone. And that's nice. It also comes with some challenges because we all have to share the money. A normal work week in Denmark is no longer than around 40 hours a week. And then, some of us put in some extra work, but no one can demand of you work more than 37.5 hours per week. You may also know that Copenhagen is our capital. It's on the far east coast of Denmark, and I'm on the far west coast of Denmark in a town called Esbjerg, as Jas mentioned. And this is some of Esbjerg, and it's a city that's a couple of 100 years old, based around its harbor. We have nowadays a lot of windmill industry. Luckily, it's green energy. So we have a mixture of blue and white collar and pink collar workers in our area. And we service around 300,000 people. So I guess a lot smaller than here. And our hospital is located in the center of the city. That's the white building in the back. And that's where I work. And as Jas mentioned, I have been working quite hard to establish a liver research group. The thing at our hospital is that it's a relatively new university hospital. we're affiliated with the University of Southern Denmark, and we just last year started training medical students. So that put a lot of focus on research, because researchers have to be the ones teaching medical students. So I had the opportunity to form this group, and I've been working on that since 2017. And that was when I was doing my postdoc research. And I've been lucky to find a very good group of people. Unfortunately, or how should I put it, it's only women in the liver research group. So I'm definitely in the market for men scientists. We are a bigger group because I'm also head of the gastroenterologists. And so we have 2 surgeons in our group that focus on colorectal cancer, and also a group focusing on diagnosing Crohn's disease with AI and camera and so on. But in my group, we have now these 3 main projects that we run. One is on hepatic encephalopathy, which is my long-standing research interest, and one that I share with Dr. Bajaj. And then we also started quite a large collaborative study with some basic scientists in the university, focusing on metabolic dysfunction-associated steatotic liver disease. And we recently also started looking into palliative care and how we can design a palliative care interventions for patients with liver cirrhosis, because actually these patients, only around 50% are alive after 5 years. So they have a very poor prognosis, and at some point we should be kind of embarrassed that we haven't already got this in place, but we're working on it now. And this is actually a study with 4 sites. So it's been exciting. And but now, since I've achieved this goal and I feel that things are running back home smoothly as they should, I have good people around me, I thought that it's time to take some time abroad again. I was here the first time in 2015 during my PhD, where I was here for 3 months. But I managed to get some funding for staying here 10 months this time. I'm a Fulbright scholar, and I also got some other funding from my hospital and from some funds back home in Denmark, the Lundbeck Foundation. And one of the interesting things I got to experience was a visit to the American ambassador's house in Denmark. And that's where the photo is from. I went there with my daughter, since both her and her brother are here with me, and they're in high school. So we've been here since August last year, and we will be leaving at the end of June. Okay, so now to the more serious stuff. I don't know, are there any questions at this point about anything relating to Denmark? Would you want to pay 50% of your income? You would, for free healthcare and education? Certainly has many advantages. Yeah, but 50% is a lot of money, right? Yeah. I guess being filthy rich in Denmark is very rare. There's not that much inequity in Denmark in that sense financially. So I'm going to focus on inequity in my talk, and I'm going to give you 2 examples of how we have been working with inequities and how to mitigate them as a part of clinical research. And all of this research I'm going to present to you is very, patient-centered. So I hope you'll find it interesting, and feel free to interrupt me. See, the thing is that what we have now, at least in Denmark and probably also here, that's equality. So we kind of offer the same type of healthcare to everybody, right? So that's the first picture. And what we really want to achieve is equity. And the reality on the on the right is probably reality. Some people have very good healthcare coverage, or here in the US, some people have very, very good caregivers that make sure to take them to appointments and all of that, and others do not. So the first example I'm going to give you is actually about dental care, and that's because Jazz had written a research protocol centered on dental care even before I got here, and I got to work with that protocol and help initiate the study. So dental care was not something that I knew a lot about initially, but we warmed up by writing a commentary for gastroenterology earlier this year. And the thing is, in liver disease, it's really that if you look at, up here, like lifestyle, diet, alcohol, dental habits, that will impact your oral health even before cirrhosis. And that's true for all of us, right? And then this will alter your microbiome, your oral microbiome. And it will give you the various orodental problems like periodontitis, for example, where bacteria can live at the root of your teeth or in the pockets around your teeth. And that can be true for any of us, but those who have metabolic dysfunction-associated liver disease or diabetes, they're at a higher risk. Then as the liver disease develops, the gut microbiome will change, and some will have endotoxemia, where bacterial products will actually leak over into the blood and cause inflammation. And patients with liver cirrhosis, when they get to that stage, they're quite immune incompetent and very prone to infections. And sometimes these infections actually arise from the teeth, and we tend to overlook that very much. It's not rare that we have a patient admitted to hospital with cirrhosis and infection, and we look everywhere to find out what's going on. And you know, even on MRI, the periodontitis might not even show. So this is something that maybe we need to focus a little bit more on. So that's what I learned from the literature. I also learned that across the world, actually, dental care utilization depends on the wealth of the inhabitants and on co-pays. And this might not be a surprise, but the socioeconomically disadvantages, they use dental care to a lesser extent. So that's the inequity here, because patients with liver disease, they definitely fall into the category of socioeconomically disadvantaged, you know, for a large part of them, not all, of course. Okay, so in that commentary we wrote, we came with a bunch of recommendations on how can we improve this. And we also gave some recommendations for research. And Jazz was light years ahead and had, as I said, already written this protocol. And we kicked off a study where we actually offered dental exam and dental cleaning for patients with cirrhosis. And what we wanted to do was we wanted to see how their oral health was, but we also wanted to ask them why they hadn't prioritized oral health earlier. And there were also actually some of them that did not choose to schedule an exam, even though it was paid for by the study. And we wanted to ask them, why is that, to find out what are the barriers here? Because defining the barriers to healthcare is essential if you want to work with inequity. Okay, so these are the data that I took out yesterday. We're aiming for 125 patients in this study. And at this point, we have 60 included, and 50 have scheduled an exam and a cleaning, and 10 signed the consent form, but then decided not to have an exam anyway. And it's probably not a surprise that 1/3 thought that the copay was a problem. And then quite many of them said that they hadn't prioritized dental health sooner because they had enough on their plates with the liver disease alone. And some of them have other diseases than the liver disease. And in that ranking that they made for themselves, the dental problems that they knew they had was just not that important. So what I took from that was probably that these patients have a lot to worry about, and therefore it could be very important to implement or educate people about the importance of dental care already when they have the risk of liver disease. Yeah, people said they scheduled the exam in the study because it was paid for, kind of lines up with the other answers. And they wanted to feel better about themselves, and some of them knew that they had dental issues. So it's not that they are not aware of dental issues and they want to do something good for themselves, but they just can't, overcome it. And sometimes the finances are a problem. Sometimes it's the other diseases they have to deal with. And then there's the small group that didn't schedule this is 10 patients at this moment, so it's not a lot. And actually 7 of them said that it was transportation problems that was the issue. It seems that, because also 70%, they had told us that they had reestablished dental care elsewhere. So I think that this is probably because, we contacted them to be in the study, and they thought, oh, well, dental care is probably important, since we're saying it. And then they chose to find a dentist in their area. I think these are probably people that live, far away from here. Yeah. So that was the dental problem. So, we're not there yet with the full study, but I think it will definitely help us find out how can we do this differently. So then another discussion is that if our results and the results of others show that copays is a problem, or that them having enough to worry about is a problem, then how do we work with that? And copays is obviously a difficult discussion. And here it concerns primarily people's health insurance. And in Denmark, it would concern, evaluating if it's something that we want to spend our public healthcare funds on. And for the thing about people having enough to worry about, I was thinking that maybe we should, implement it much sooner and have it as a package deal, as they have, at least in Denmark, for people with diabetes. They see a foot therapist and they see the eye doctor, because we know that they are at risk. So that could be something to consider. Any comments at this point? Okay, so I'm going to give you the next example of how we try to,
Sorry, quick question. So is there like any way to assess the risk of cirrhosis to know which patients I need to refer them to the dentist as like a prevention for worsening of the cirrhosis? Now, I mean, it should be recommended for all patients, regardless if they're at risk for cirrhosis or not. Like, is there a specific tool that I can use for that?
There's not a specific tool. We have I don't know if you know, but we have FIB4 for screening for fibrosis. So that's definitely one. But I would say, diabetics, even those that have steatosis of the liver, and those that drink in excess, they would be your risk population. So it's just where you want to, put the cutoff. Because in an ideal world, we should all see a dentist to make sure that when we get sick and our immune system is compromised, then we're not killed by bacteria that live in our oral cavity. That's a shame. But what are there anyone working with patients that also have immune deficiency? Yeah. Are they screened for dental problems? And what kind of patients are they?
So I'm a transplant infectious disease physician, so all of my patients are compromised. But I mean, when you're talking about like the people who are severely neutropenic after stem cell transplant or something like that, usually, I mean, there's certain periods of time where it's better for them to see the dentist, just dealing with bleeding issues and things like that. Also, but it definitely, like, whenever we see patients and it's clear that they haven't gone to the dentist, that's always part of what we say. But the timing can be a little challenging when people are already in that state.
Yeah.
And certainly, like, in the pre-transplant evaluation, if they haven't gone to the dentist and visibly have worrisome findings on exam, we make that recommendation also. But again, the timing can be a little challenging.
Yeah. So basically what you're kind of supporting the notion that, if it as early as possible.
Absolutely.
Yeah.
There's a question online whether Denmark covers dental coverage.
Yeah, actually they don't, but you have to pay something yourself, and it can be quite expensive. So all up till you're 18, everything is covered. So, in general, Danes have, nice teeth. You can easily see the countries in Europe where they don't cover dental care, from childhood, because they will have a lot of crooked teeth, to be honest. But till you're 18, everything's covered. And after that, some is covered. But it is actually quite expensive. And also with my patients back home with cirrhosis, some of them have very few teeth because they can't afford to get it fixed. And I try to refer them to the periodontist, and they're kind of like, nah, this is not a problem. And I have to argue, well, he can't eat. And yeah. So it's an issue in Denmark too, because our healthcare coverage goes far, but not that far. Okay, so moving on to the next example, and that's going to be about obesity and muscle D. It's no surprise to any of you, I guess, that we're getting fatter. And as in many other areas, you're way ahead here in the US. And these are data from the World Obesity Federation suggesting that in 2035, 60% of men and women in the US will have a BMI above 30. And that's 40% for Danish men and lower for Danish women. But, we're also getting there. So that's kind of wild and scary. So we know in hepatology that we are going to see a lot more patients with liver disease caused by metabolic dysfunction. That's just a fact. And there are also inequities when it comes to obesity, because if you are socioeconomically disadvantaged, you are at higher risk of, being obese. And also in terms of developing liver disease because of obesity, you have a higher risk if you are socioeconomically disadvantaged. And that's actually not only true in terms of obesity-related liver disease, it's also true for alcohol. If you have two people, they drink the same amount of alcohol, but one, is well off and the other's not, then he's at higher risk of progressing in his liver disease. Yeah. And, the progression is from healthy liver to muscle D, where you have steatosis in the liver, that can progress to steatohepatitis, where you also have an inflammatory component. And that's actually from that point that the real trouble starts, because the steatohepatitis is a driver of fibrosis formation. And then you can end up have cirrhosis with all of the complications it comes with, including liver cancer and premature death. And liver disease is actually, or liver cirrhosis is one of the, primary organ diseases when it comes to killing people at a relatively low age. Yeah, you heard that before, right? About this progression. Yeah. Okay, so back home in my hospital, we have a special focus on obesity. The thing is that we have Novo Nordisk back home, and they kind of come in as a huge player actually in public welfare. So they, to some extent, fund a lot of our, endocrinology evolving around obesity. And that's something completely new. But I think that their thought was, we really want to do something good for these people. We have a lot of money. So they gave a bunch of money to the public welfare. So it's not that they decide how we can spend the money. We decide that in the hospitals. So in my hospital, we opened an obesity clinic in collaboration. It was actually the endocrinologist that opened this, a professor there. And I'm one of the collaborators in the clinic, because the idea is that general practitioners and also other specialties in the hospital, they can refer anyone with a BMI above 30 to that clinic. And at the clinic, they will have fibro scanners to assess liver stiffness, liver fibrosis, and lots of measures of sleep apnea, cardiovascular disease. So they'll kind of get a full workup. And then patients, depending on what we find, trickle down to the specialty where they need to be seen, and some to several, right? that's how it is in Esbjerg. And it's been running for 3 years now, and it's been a success. We made some adjustments along the way, but generally it's been a success. And actually now they're making it available also in the 5 other hospitals within our region of Denmark. And that obesity clinic and the fact that we are the only hospital in the region that does bariatric surgery allowed us to start a collaborative study with a center of excellence called Atlas at our affiliated university to try to recruit patients with a BMI above 35. And we want some that are going to have bariatric surgery. So that's the one arm, and also some with a similar BMI that's not going to have bariatric surgery. Then at baseline in all of these people, we want to take a liver biopsy. But with my long-standing interest in cognition, I thought, why don't we see how their cognition is? So that's also something that we do at baseline. And then they come in for another biopsy during surgery, those that are undergoing surgery. And then all of them for a finishing biopsy 2 years after surgery, or an equivalent time point. So for some, it's a triple biopsy study. We also biobank saliva, blood, stool samples, and urine. So it's a lot of biobanking, and we also take some adipose tissue from the site of the biopsy, some subcutaneous adipose tissue, because one of the basic scientists that we work with in the university, she's actually researching adipose tissue. So it's a really, really cool project, tough one to get started in an organization where there wasn't a lot of research infrastructure to begin with. That includes a biobank, but we got it running. So at this point we have around 300 participants in the study. And I was actually going to tell you a lot about cool biomarkers that we discovered, but I thought it's more fun to talk about actually the cognition, because that's more relatable to all of us, regardless of what specialty you're in. So when we had 180, we kind of looked at the baseline cognitive samples in these patients, and 70% of them approximately are women, and that's just how it is. I don't know how it is here, but at home, 70% of those who undergo bariatric surgery are women, and it's not because the obese men are not sick; they're just not seeing a doctor or interested in getting surgery. Yeah, so that was the group, and they're 46. That's my age, and they all had a liver biopsy and cognitive testing. So these are, people that are, active in the middle of their life with kids, jobs, and all of that. Yeah, and so we did 3 cognitive tests in all of them, and then in a subgroup we did a more extensive test. One test they did is called continuous reaction time test, and that's where they have headphones and a trigger button, and they have to respond as quickly as they can to sound stimuli that comes at random intervals 150 times in a row. So you really have to be able to not think about what am I going to have for dinner, all of that. You really have to stay focused for the 10 minutes of the test. But every one of you can do it, I bet. The portosystemic encephalopathy syndrome test, maybe you can figure out that that's one that we actually normally use to find hepatic encephalopathy, and that's a paper pencil test. For example, it's 5 subtests. One of them, for example, is you have to connect some numbers, kind of like kids do, from 1 to 2, 3, 4, etc. And you time their performance. And then we did a Stroop test. Do any of you know the Stroop test? It's been used in research of hypertension, actually, originally. We have it on an iPad, so it's you see like a pound sign in either red, green, or blue, and you have to indicate what color it is. And then the next phase of the test, you see, for example, the word green, but it's written in red, and then you have to indicate that it's red. It's the color of the word. It's kind of difficult, actually. So we really put them to a test. And then the longer, more extensive test, the R-bands, that's where we also test their short and long-term memory. So we went all in with the cognitive testing. And we had a bit of a struggle we wanted to define a group that was cognitively impaired, but to be honest, they should all have been able to do all of these 4 tests, within normal range if they had been normal. But there were like over half failed the continuous reaction time test. And there were also problems in some of the other tests. So we kind of decided that this algorithm, so we kind of made quite, we were nice to them so that we only identified the 35 as definitely cognitively impaired. 40% had more than 2 abnormal tests, but only 35 of them fell into our category, our definition of cognitively impaired. And actually, they had memory problems, which was quite surprising. And we found on our analysis that the males were actually, it was associated with a higher risk of being cognitively impaired if you were male. Then also lower LDL cholesterol, and maybe not a surprise that if you take psychoactive medications, 2 or more types of that, then you're also at higher risk of being in the cognitively impaired group. And the thing that was striking here, I think, is that it was actually how many of them that took these types of medication. Many of them took at least an antidepressant. And on top of that, a lot also took like venlafaxine and stuff like that. That's a bit more on the heavy end. But the liver disease in itself had nothing to do with the cognitive problems. And that was my interest point, because I'm used to looking at hepatic encephalopathy that is caused by liver disease. So I was interested to see, well, in these milder forms of liver disease, will that actually impact cognition? But that was not important. Male sex and psychoactive medications was the most important. So what I take from that is that with some of these people, not all, still the majority did well, but some of them had maybe what we could call a composite metabolic dysfunction. Hepatic encephalopathy, that's a metabolic brain disturbance. There's nothing wrong with the brain itself. It's more the environment surrounding the brain. And it might be the same here. I know that there is a term of diabetic encephalopathy. So this is probably a combination of those things, or it could be something that was there in advance. We don't know that. But right now we are waiting to gather enough data to look at what happens after bariatric surgery, because if they improve their cognition, then it speaks to it being a metabolic encephalopathy. And if it remains the same, then maybe they've had these cognitive problems all along. So then we asked about quality of life. And before I go on to that, do any of you have any thoughts on this? Yeah.
There's been a bunch of data in primary care settings that about 20% of older adults have undiagnosed cognitive impairment. And just trying to fit these pieces together because of what that data says and then what this study says. And I guess, do we know the sort of way we think about impairment and how this would fit in? We always think about it in terms of, are they safely able to operate a vehicle based on what we know about alcohol content and things like that?
Yeah, I also looked a lot into the literature to see, what others had thought about this. And actually, it hasn't been studied very much in obesity like this. But definitely, it seems that obesity is related to some kind of premature aging of the brain. So it might actually be that, and that what you're saying is the same as I'm observing here, just in younger people. But because of their comorbidities, their brains might be aging. I also read something about, cholesterol lowering drugs. That's good for cardiovascular disease. But there are actually some literature out there suggesting that it might not be good for the brain, because the brain is, 100% fat almost. So there might be some disturbances also caused by that. But when I looked at my data, I couldn't see that being on statins, for example, had any impact. Yeah, so it's surely complex. I think it's just quite striking because these people, as I said, are, they're active. They should be working, living their lives. And instead, this relatively large fraction of them actually, struggle with cognitive issues. Yeah. And their struggle leads me to, then we looked at their quality of life. Please don't get blown away by all of these. But we used actually a quite extensive quality of life questionnaire called Sickness Impact Profile. It has 136, statements that people, say if they can relate to or not. And we didn't use any of the liver-specific questionnaires because we were pretty sure that this extended far beyond just the liver. And the pink bars here, that's people with MASH. And then we put a group in of patients with liver cirrhosis, which are the blue bars. And you can see that in many aspects of daily life, people with MASH feel just as bad or has just as many difficulties as patients with liver cirrhosis. So that's quite striking. And even if you look out here, the sleep and rest and emotional behavior, home management, then the MASH patients actually report being, having greater difficulties than patients with cirrhosis. So that's probably because, demands are higher if you're in your 40s as compared to our cirrhosis patients are somewhat older. Many of them are retired, or at least they're not working. And also to some extent, I know this patient group of cirrhotics, and some of them may also actually not, they don't realize that they're not functioning regarding home management or whatnot. So yeah, some of the hepatic encephalopathy that sets in cirrhosis actually hinders you from seeing your own limitations. This is difficult to see, right? But I just wanted to show you what statements really stood out here in the patients with liver disease caused by metabolic dysfunction. And I looked at them, by hand, and I only wanted to, include statements that more than 40% had indicated was a problem. Some of it is emotional behavior. You can see that 48% of people with MASH say that they moan or groan in pain. They keep rubbing or holding areas of my body that hurt or are uncomfortable. I do less work around the house. Their sexual activity is decreased in 59%. They're doing fewer social activities, and they're concerned about their health. They forget. So that's exactly what we found on the cognitive testing. And I can't keep my attention for any activity for long. Also, many people stated that. So those are the problems that they experience in their daily life with MASH. That's the steatohepatitis. You don't have to take all this in. So the things that correlated to a poorer quality of life was being out of a job and being divorced. And then the only somatic factor that really correlated to a poor quality of life, that was steatosis. So it tells me that there are many factors that apart from just the somatic health that impact quality of life. But it seems that, once you have fat in your liver, that may be somehow a driver of a lot of bad things, including mental health and cognition. So just to sum up, 40% were uncomfortable, fatigued, distracted, no job and being divorced, and depression was also on there, not so surprisingly. That was associated with a lower quality of life, and hepatic steatosis was the only somatic factor involved in it. It's biologically plausible. That's why I brought this slide. I just spent some time looking at the pathophysiology behind fatigue and frailty and cirrhosis. And I think a lot of these things are present already in steatohepatitis without any fibrosis, or with very little fibrosis. The hormone disturbances, for example, as low cortisol caused by chronic inflammation, certainly a fraction of the obese males have low testosterone as well, and that also impacts insulin resistance, and hepatic inflammation will cause impaired mitochondrial function and lower energy levels in general. So it makes sense. And to go back to the disparities and inequities, so how can we use this knowledge to try and do better for these patients? And what I thought a lot about was that we should start doing more in terms of point of care screening for these types of liver diseases, because at least we know the men, they are very poor at seeing a doctor for themselves. So maybe if we were present out there in the community some more. I don't know if that's a thing here, but it's definitely something we're hoping to be able to do more back home in Denmark. You have clinics around the area, right? Here, affiliated with. Yeah, and as I said, maybe a similar setup as to type 2 diabetes, where you have like a compound care, like a healthcare package that includes all of the problems that you know can occur, for example, in people with MASLD. And then we have to remember to tell people about this. The patient that comes in, like, for example, a young woman my age, you know, if she's very, very fatigued and, you know, this might cause her some problems, I think it's important to make her aware that this is actually probably caused by your obesity, and there's hope it can get better, but help them, you know, prioritize their energy. And then I also thought that maybe in some of these patients that are very fatigued, it would be important to have weight loss interventions like GLP-1 analogs up front to help them get a head start on weight loss. Because what we do now is we can't prescribe GLP-1 analogs until, you know, we've said to them, you have to go home and lose some weight. Well, that's maybe not totally fair to someone who has fatigue to an extent that's the case here. Yeah, and then also those are on antipsychotics. I think there's a very bad interplay going on there with these antipsychotics. They are actually causing hyperlipidemia and steatosis of the liver, and they themselves might actually, the drugs might actually cause a huge weight gain. So I think we need to focus a lot more on that, because a striking number of the obese patients in my cohort are actually on this type of medicine. Yeah, that was my examples. Any comments, questions? Yeah.
Started answering my question about GLP-1s, and I was just curious in Denmark, the access to those medications and how it might be different from here.
Yeah, they're very accessible. You also get them with, you don't have to pay the full amount for them. So, you know, the government will cover some of it. And actually, there have been a lot of news stories because, you know, at the rate that these are being prescribed, it's just, you know, emptying all of the funds for meds. So, yeah, I don't know what your opinion is on it, but I'm thinking that it's probably better to give people the GLP-1 analogs than wait till they get cardiovascular disease and maybe, you know, in need of bariatric surgery.
Yeah, I mean, I think like referring someone for bariatric surgery and the risks of 3 biopsies, like it would be good to see some intermediate option for some of these patients, I think, and a GLP-1,
yeah,
I think offers that potentially to patients.
Yeah. And now, I don't know if they're available here, but the combination with GIP and GLP-1, are they available here for?
The 2 hormones.
Okay. Yeah, because that's supposed to induce an even bigger weight loss than the GLP-1s. So I'm kind of hoping that in some years we will stop doing bariatric surgery. Seems like such a, you know, seems very, very invasive. So yeah, I think, you know, in very few years, this will be reserved for very special cases. Yeah.
in Denmark, can a general practitioner provide or prescribe the GLP-1, or does it have to come from one of these interdisciplinary?
The GPs can, yeah.
Out of curiosity, what is Denmark's approach to, I guess, access to healthy food options, rates of food deserts? Because I think, at least in America, that ends up being one of the primary drivers of obesity, in addition to other socioeconomic factors.
Yeah.
But if you think about like, hey, where can we optimize our tax dollars or healthcare dollars? I wonder if that's, bigger bang for your buck.
Yeah, healthier food options.
Yeah.
Yeah, I agree. Like that's the early prevention. Right? If we could all just eat healthier, because people are on probiotics and whatnot, and in reality, you could just skip the probiotics and eat, in a healthier way. So I think that's crucial. And you have a lot of fast food chains here, and I think that eating out is relatively expensive in Denmark. I think it's relatively cheap here when you think of what it costs to go to Publix and buy, shop for getting your a sandwich. Then it's almost as cheap to go to Chipotle, right? Yeah, so I think that's a problem here right now, and it is so available here. And also, you don't ride your bikes. You don't have biking lanes. Yeah, so yeah. You ride your bike, okay. Yeah, I rented a house out in Henrico and really close to my kids' school. So I thought, they'd be off on their bike. I don't have to worry about them. But I find myself, taking them to and from school because I'm afraid they'll get killed in traffic if they, walk for 15 minutes. Yeah, so that's definitely a thing too, I think. I don't know if you've been to Copenhagen to see how people ride their bikes. It's crazy on the bike lanes in Copenhagen, and people ride around with their kids in these trailers or in front of the bikes, and it's fun, but yeah. So maybe you should work on that too.
Yeah, Alex.
Yeah. Thank you for listening.
Yeah, thank you.